Good morning, everybody. So today we'll be looking into expansion and more into the indications, contraindications of rapid maxillary expansion. So the basic contents we'll be covering will be the introduction, historical background, applied anatomy, classification of expansion, etiology of maxillary expansion, indication of maxillary expansion, types of expansion, and RMD. So, arch expansion is a method of gaining space, and it is apparently a complex but relatively a simple procedure in orthodontics. So, the need of expansion is primarily for the need of correction of transverse maxillary deficiency, and it can be an important component of orthodontic treatment plan. So when you look at the historical background, the first uh, expansion appliance was used by Emerson Angle back in the 1860s, and ever since then, more innovations or more work into the part of expansion has been done, and more or less we have got multiple appliances that are there in the current day orthodontics that can be used for the correction of the maxillary transverse deficiency. So when you look at the anatomical point of view, what is the most important part that is, that has to be kept in mind is the mid-palatal suture itself. Because for advantage of expansion, the maxillary arch is greater than in mandibular because the mandibular symphysis is the one that connects both the halves of the mandible, which fuses at a much earlier age when compared to maxillary mid-palatal suture. So we have a more scope of expansion in the maxilla rather than the mandible. Bertie Melson had very clearly classified the morphology of mid-palatal sutures, where she divided it into three stages. The first stage being the infantile period, in which the suture is very broad and Y-shaped, with the vomerine bone placed in the V-shaped groove between the two halves of the maxilla. So if you look at the image below, you can see the Y shape, where the V shape is the vomerine bone, and the other two halves are the two halves of the maxilla. On maturation, and when the child reaches the juvenile stage or the suture reaches the juvenile stage, the V shape or the Y shape flattens out, and the VY part flattens out, and the vertical part has a developing curves. So if you look at the image, you can see the grooves that have developed. And the last stage is your adolescent stage, where you have a demarcated and extensive interdigitation that is seen with the full maturity of the suture. So RMA should always be initiated prior to full ossification of the mid-palatal suture, and transverse growth is said to be lasting till 16 years of age in girls and up to 18 years in boys. But whereas when you look at the clinical perspective, it seems to occur at a slightly earlier age. So when do you do rapid maxillary expansion or transverse corrections? The main indication, like we said earlier, is because of maxillary transverse deficiency. Maxillary transverse deficiency are clinically seen as cross bites, where you don't have proper intercuspation in the transverse plane. Second would be to correct mild to moderate crowding. Third would be expansion indicated with functional appliances. The fourth one is your skeletal correction. It is mainly in class 3 correction when you are giving a face mask therapy. You might need to expand the maxillary arch so that the maxilla can accommodate the mandible within the maxillary arch. Some sort of expansion are also given in for distal molar movement during usage of orthopedic appliances like your headgear. Surgical orthodontics also involves the need of expansion with the same way where we are creating adequate space for the maxilla to accommodate the mandible within. So how do you classify expansion? Expansion broadly can be classified into three. That is your orthodontic, where you use appliances or like jack screw and removable appliances mainly. You have your orthopedic expansion, where you have skeletal expansion occurring, where you use expanders like your Hyrax, etc. And you have your passive expansion, where you use Frankel appliances or your vestibular screens. The more broader classification of expansion is like shown, where you can divide it into three. slow, rapid, and surgically assisted. Now, currently orthodontics have been changed where you have a fourth one that is also incorporated, which is an alternative to surgery that is called as mini implant assisted rapid maxillary expansion. So, slow maxillary expansion can be further divided into removable appliances and fixed appliances. Removable appliances include your things like your coffin spring and your active plates, or fixed appliances which include your Cordelix or W arch. Rapid maxillary expansion can be divided into tooth and tissue bond or tooth bond appliances, with tooth and tissue bond having Derris Wheeler and Haas type, and tooth bond having your Isaacson and Hyrax type. So, what leads to maxillary transverse deficiency? Maxillary transverse deficiency can have a plethora of etiological causes. Some of them are your habits, like your mouth breathing, your thumb sucking habit, and others being your OSA, that is your obstructive sleep apnea. Iatrogenic causes like early cleft repair. It can be inherited or genetically induced. Muscular hypertrophy, so overusage. So this is correlated with the habits where you have your mouth breathers. They can have increased muscular activity on the arch itself. Some others being your syndromes, cleft lip, cleft palate, craniosynostosis, non-syndromic palatal synostosis, that is early fusion of your sutures, or they can be multifactorial. So RME, how do you diagnose that you would need RME? So the primary always being case history, clinical examination where you intraorally examine the patient, and you have x-rays that would help you to do so also. Evaluating study models and doing the necessary model analysis to find if the patient is in need of expansion or not. Maxillary occlusal radiographs to in order to identify if the fusion of the mid-palatal suture has occurred. PA lateral cephalograms can also help in identifying if there is a deficiency of said so. So the image here is of a PSF which can be used to analyze if the maxilla is in need of expansion or not. The image on the right is showing where treatment was done and the opening of the suture can be appreciated. So by doing RME, what are the effects that come into play? The first and foremost is your maxillary skeletal effect, where RME leads to opening of the mid-palatal suture. How does the opening come about? It is a V-shaped opening that takes place, where you have more opening in the anterior region than your posterior region. The effect on alveolar bone is by bending of the bone itself. So the alveolar bone is generally resilient in nature. Henceforth, when force is applied, they tend to slightly bend in the direction of the force applied. Effect on the anterior teeth are very common and very easily appreciated as they present as midline diastemas. The posterior teeth, so this effect is slightly the unwanted or the reciprocal effect that occurs. That is, the inclination of the posteriors tend to change. So they tend to incline in the direction of the force applied. So how it is seen is they will be seen as more of buckle tipping of the posteriors. The effect on the mandible can be seen as a clockwise and downward rotation of the mandible. So henceforth, the expansion has to be always indicated in by also evaluating the growth pattern of the patient. So these are the general factors that you need to look at when you are planning for rapid maxillary expansion. And they also have an effect on the cranial bones and sutures also, where they tend to open up the cranial sutures also, and it also plays a critical role in the nasal cavity, whereby it increases the nasal airflow of the patient also. So I hope you have understood the general indications of RME and how or what effects they bring about on the craniofacial sutures itself. Thank you.